Hi everyone. Today we are going to discuss about malignant melanoma. Malignant melanoma is a malignant neoplasm with its origin in the neural crest cell. It was first described by Weber in 1859. Luke in 1869 recognized it as a distinct clinical entity and named it as melanotic sarcoma. Oral melanomas represent about 1 to 2% of all oral malignancies. Melanomas account for about 3 to 5% of all malignancies affecting the skin. Risk factors for melanoma include tobacco smoking, which may play a major role in the development of melanoma in the palate, fair complexion, light hair, exposure to formaldehyde, exposure to UV radiation, family history and genetic predisposition of malignant melanoma and dysplastic nevi are few of the other risk factors. Classification of melanoma includes Breslau's classification and Clark's classification. Under Breslau's classification, we have 4 types. Type 1 includes melanoma less than 0.75 mm. Type 2 between 0.76 to 1.5 mm. Type 3 1.51 mm to 4 mm. Under Clark's classification, we have 5 levels. Level 1 includes melanoma only in the epidermis. Level 2 includes melanoma extending into the papillary dermis. Level 3 includes filling of papillary dermis completely. Level 4 extension into the reticular dermis, and level 5 extension into subcutaneous tissue. Moving on to the clinical features, melanomas are most common in 4th to 7th decades of life. It is seldom seen in the individuals below 20 years of age. Males are usually commonly affected than females. Melanoma is 5 times more common in the whites and more common among Africans, Japanese, and Hispanics. In oral cavity, it is most commonly seen in the hard palate and maxillary gingiva, and it is least commonly seen in buccal mucosa, lips, tongue, floor of the mouth, and the mandible. There are 5 types of melanoma, which includes superficial spreading melanoma, lentigo-maligna melanoma, acral lentiginous melanoma, nodular melanoma, and amelanotic melanoma. Superficial spreading melanoma is the most common type of melanoma, and it usually arises from a pigmented dysplastic nevus. Ulceration or varied coloration are seen. It is most common on head, neck, and trunk of males and the lower extremities of females. Lentigo-maligna melanoma is the least common and least malignant melanoma. Common in older individuals, originates from a melanoma in situ or Hutchinson's freckle. Acral lentiginous melanoma is most common oral melanoma. Initially, it appears as a macule, slowly shows nodular appearance. Also affects palms and soles. Nodular melanoma is common on trunk of males, symmetrical and uniform, dark brown or black in color. The radial growth phase may not be evident. Amelanotic melanomas represent approximately 5% of all nodular melanomas. Amelanotic melanoma is the worst form of melanoma. Because of the undifferentiation, tumor cells lose their capacity to synthesize melanin. It presents as pinkish, fleshy growth which is rapidly progressive. It may mimic soft tissue sarcoma. Warning signs in a mole suggestive of early melanoma are asymmetry. One half of the lesion does not match the other half. Border irregularity. The edges are ragged, notched, or blurred. Color variation. Pigmentation is not uniform and may display shades of tan, brown, or black. White, reddish, or blue discoloration is of particular concern. Diameter. A diameter greater than 6 mm is characteristic. Evolving. Changes in the lesion over the time are characteristic. Now let's see about staging of malignant melanoma. Stage 0 includes melanoma confined to epidermal region of skin. Stage 1 includes localized disease only in the skin and it is very thin. Stage 1A, thickness less than 0.76 to 1.5 mm. Stage 1B, thickness between 1.51 to 4 mm. Stage 2 includes localized disease thicker than Stage 1. Stage 2A, thickness less than 0.76 to 1.5 mm. Stage 2B, thickness between 1.51 to 4 mm. Stage 3 includes spread to lymph nodes. Stage 3A, any of the above including regional lymph nodes less than 3 cm. Stage 3B, thickness more than 4 mm including nodes more than 3 cm. Stage 4 includes spread to other organs, any of the above, any node, and distant spread. Self-assessment tool for diagnosis of melanoma used is ugly duckling stage. It can be used as an effective self-examination tool. Individuals are asked to compare the gross appearance of the moles on their body. Usually, all the moles will have similar topographical appearance, except for the ugly duckling. Scope et al. In 2008 assessed the effectiveness of the ugly duckling sign as a potential screening tool for malignant melanoma. Histological features. Histologically, a high concentration of the melanocytes may be seen in the biopsy specimen. These atypical melanocytes are larger and exhibit nucleopleomorphism and hyperchromatism in the epithelial and connective tissue junction. Differential diagnosis of melanoma includes oral melanotic macule, smoker's melanosis, amalgam tattoo, Addison's disease, melanoplakia, Peutz-Jeghers syndrome. Management of melanoma. Melanoma is best managed with surgical excision of the lesion with wide margins of at least 2.5 cm. Widespread disseminated metastatic disease can be managed with chemotherapy and radiotherapy. Some authors have reported good result with interferon. Prognosis. Prognosis of oral melanoma are poorer than skin lesions. The prognosis of the condition depends on the extent of invasion. When the invasion is limited to the epidermis, the condition is almost 100% curable. When the lesions are less than 1 mm in thickness, the 5-year survival rate is about 95%. When the lesions are more than 4 mm in thickness, the 5-year survival rate falls to 45%. The 5-year survival rate for oral melanomas is about 10%. Thank you.